pH of our blood should be between 7.35 and 7.45. Anything above 7.45, we call that alkalosis. Anything below 7.35, we call that acidosis. There could be our lungs or our kidneys that could be the cause of this. So if it's our lungs, we call it respiratory acidosis or alkalosis. If the kidneys are the cause of it, we call it metabolic acidosis or alkalosis. In this video, we want to look specifically at respiratory acidosis. So respiratory acidosis involves a buildup of too much carbon dioxide, which is a weak acid. If we have too much acid in the body, it causes acidosis. And our lungs aren't properly ventilating this volatile gas / acid out of the body. So look at the chemical equation here. When carbon dioxide meets water, which is anywhere in the body, it becomes a weak acid called carbonic acid. If carbonic acid dissociates, it can become a hydrogen ion and lower the pH, as well as a bicarbonate ion. So what's nice about a weak acid and a weak base is it can act like a buffer and resist pH change. So if our system in our blood, if it's too high, this may go to the right and release hydrogen ions, bringing the pH lower. If our pH is going too low, so we're going towards acidosis, this would want to shift to the left and tie up all our hydrogen ions into molecules where they no longer have an effect on our pH, bringing it down. So that's Le Chatelier's principle, just kind of going towards equilibrium. And with respiratory acidosis, if you have a patient and they have this new onset delirium, like a confused and then somnolescent, just really tired, you might want to check and see how their pH looks and make sure they don't have respiratory acidosis. So that's the common symptoms. What are some of the causes? Because obviously, if you have respiratory acidosis, you want to eliminate the causative factor or fix it so that everything can work back out. So the common causes are impaired respiratory drive. There's a couple things that could cause impaired respiratory drive. So in our brainstem, we have the three parts, the medulla, and right above that, the pons, and then the midbrain. In the pons and medulla is all of our breathing centers, the nuclei responsible for controlling our depth of breathing, the rhythm of our breathing. And so if for some reason, some medications like benzodiazepines, which include Valium, Xanax, Ativan, these can actually depress those rhythms, these respiratory centers, and reduce the heart rate so low that you can't breathe off enough of that volatile acid, carbon dioxide, and it'll build up in the system. Also, you could have a brainstem stroke where you have an infarct to the area that controls your breathing, and that could also throw it off and depress the respiratory drive. Another common cause, probably much more common than those, would be pulmonary issues such as asthma, COPD, fibrosis, like pulmonary fibrosis. So this will be like asthma is where you can have this inflammatory reaction where the bronchioles and the airways and the bronchi kind of constrict, and then you can't get all that carbon dioxide out because the airways are narrowed. Or COPD, the main two causes of COPD, which stands for chronic obstructive pulmonary disease, includes chronic bronchitis, where you just have this productive cough for more than 3 months over with back-to-back years. That's kind of the criteria. So it's just a productive chronic cough, and that's called chronic bronchitis. The other one is emphysema, where at the end of our airway we have the little alveoli sacs, and there are lots of small little sacs there, and that's where the airway exchange happens. The air exchange happens where carbon dioxide and oxygen are exchanged there. And so there's a lot of surface area with all those little small alveoli. But with emphysema, often caused by smoking, it'll cause destruction of those alveoli where they become just kind of like bigger sacs, and there's not as much surface area and therefore not as much room for gas exchange, and that carbon dioxide can build up that way. Also, pulmonary fibrosis, where there's just fibrotic tissue that limits the expansion of the lungs and recoil and all that. So again, you can't get that carbon dioxide out of the system. So those are some of the common causes. Normal values. So if you do an arterial blood gas, so a lot of times you go into the radial artery and you pull the arterial blood gases, you want to see your partial pressure of carbon dioxide somewhere between 35 and 45 millimeters of mercury. And then you want to see your bicarb, that's the other thing you want to look at, and you want it to be between 22 and 26 milliequivalents per liter. And of course you want your pH between 7.35 and 7.45. So you can tell a lot from these ABCs, or arterial blood gases. Let's say that you have a pH of 7.25. So that would be an acidosis. Then we got to figure out, is it a respiratory acidosis, something going on with the lungs, or is it a metabolic acidosis where there's something going wrong with the kidneys? So if we look at partial pressure of CO2 and it's high, so let's say that it's like 75 millimeters of mercury, then the pH is going down and the partial pressure of carbon dioxide is going up, and that would be indicative of respiratory acidosis. So it's inversely proportional. So as the pH goes down, the actual partial pressure of carbon dioxide goes up, because there's more carbon dioxide in our blood than there needs to be. And carbon dioxide is an acid, and so it can decrease our pH. And then in that same situation, you would see the bicarbonate within normal limits. And so then you know it's got to be the lungs that are a problem. So you can actually compensate. So, if the lungs aren't doing their job, the kidneys can come in and work harder to get rid of acid. And that's what you would see in this situation. So over time, it would take about 3 to 5 days for your kidneys to kick in. It takes longer. If it were the other situation, if the kidneys were having the problem, you can actually start breathing harder and faster to get off more acid immediately. So that can work in minutes. But with the kidneys, it's a slower process. It takes about 3 to 5 days to actually start compensating. So when you first see the respiratory acidosis, you won't see any change in the bicarbonate. But what the kidneys can do at the proximal convoluted tubule is that they can reabsorb more bicarbonate, and the tubular cells can actually make bicarbonate. So they're generating new bicarbonate and reabsorbing bicarbonate. So you would see the bicarbonate go up to compensate. So that could actually, at first, it can maybe bring the pH back into its normal limits, but you would still have a very high partial pressure of carbon dioxide, and you'd also have higher bicarbonate, because you want more bicarbonate in the blood to be a buffer and keep that pH in its normal range. So that will probably, let's imagine somebody has COPD, so they have chronic bronchitis, and at first this starts to trend up and our pH is low. Then over the next 3 to 5 days, the bicarbonate comes up. The partial pressure of carbon dioxide is still up, but our pH goes back to normal values. What if that chronic bronchitis progresses and gets worse and worse? Then the pH, the partial pressure of carbon dioxide will continue to climb. At some point, the kidneys aren't going to be able to keep up. It may and you'll still have, maybe it's like 7.3, so it would be partially compensated for, and then it can get worse and worse where it just can't compensate and the pH just, plummets. So that's a overview of respiratory acidosis, and I hope that helped you understand the topic. Thank you.